Welcome, everybody. Welcome to the IFAM seminar series, which today is held in partnership with the Buehler Center for Health Policy and Economics. I'm the director of the Buehler Center for Health Policy and Economics. Please be aware that we will not be monitoring the chat during the seminar, but if you have questions for the speaker, please use the Q&A function and we'll do our best to answer them during the Q&A if time permits. It is with great pleasure today that I get to introduce our speaker, Brendan Saloner. Dr. Saloner is a Bloomberg Professor of American Health in the Department of Health Policy and Management at the Johns Hopkins School of Public Health. He focuses on policies to improve the health and well-being of underserved populations with a focus on people who use drugs. He leads the evaluation of the Bloomberg Overdose Prevention Initiative, a major campaign to reduce overdose in 7 states. He's received grants from NIDA, Arnold Ventures, and the Greenwall Foundation. Dr. Saloner received a PhD from Harvard University and was a Robert Wood Johnson Foundation Health and Society Scholar at the University of Pennsylvania. Dr. Saloner, thank you so much for being here and welcome. And with that, I'll let you take it over.
All right, thank you. Thanks for having me in Chicago, and greetings from my house in Washington, D.C. I am going to share screen, and within the confines of this kind of talk, I welcome all the questions and interaction we can get. So, I can take questions as they come or at the end. I'm really quite flexible. So let me get my talk on the screen share, and I will maximize it there. Okay, great. So I wanted to give my talk today a title that conveyed both the sense of despair and pessimism that many of us feel around this issue, as well as the sense of hopefulness that there are possible ways to improve the situation for people who are being affected by our opioid overdose epidemic. So I'm going to just run through this as my outline for the talk today. I'm going to start by talking a little bit about our overdose crisis. I know many of you are very familiar with this, but just going to level set a little bit. And then I'm going to go through some of the research that I and my team have been doing along with other research teams on access to MOUDs, which is medications for opioid use disorder, across different touch points of care. And I will give you a definition in just a minute of what I mean by touch points, and then conclude with some directions for research and policy. So let's start off with some background. I think this picture really sums up the profound national crisis that we're all living through. Drug overdoses were already at alarming levels heading into the pandemic years. And what we've seen since 2019 is that an already very grimly accelerating overdose crisis has just swung dramatically upwards. Drug overdose is the #1 cause of injury death in the United States. It's one of the contributors to declining life expectancy in the United States. And it's a crisis that we're now in at least our 3rd decade of going through. And I think it's important not to lose sight of the real human toll of this. 1 million+ people are victims of the overdose crisis. Each of those people has a story and a face and a name. And it's just important not to let the sheer numbers take over the unique individuality of everyone who's been lost through this crisis. When we talk about the overdose crisis, we talk about a crisis that's really unfolded in waves. The first wave of the overdose crisis, of course, was related most closely to prescription opioids. That crisis really started in the 1990s with the market introduction of new and more potent formulations of opioid analgesics like OxyContin, and the increased marketing and sales of opioid analgesics. And you can see the mortality trends related to prescription opioids shown in the sort of the brownish line. And you can see that sort of that mortality started to level off around 2010. But following on that has been a crisis related to heroin, which really got started in the 2010s and the mid 2010s, which became a sort of a readily available alternative to legally prescribed opioids, and has a lot to do with changes in the markets for heroin from source countries. And then finally, the opioid crisis most recently has been characterized by fentanyl, shown in red, which overtook heroin around 2015 as being sort of the main illicitly manufactured opioid that has been driving mortality. And now many people would say that we're actually in a fourth wave of the overdose crisis related to polydrug overdoses, where many overdose deaths actually involve an opioid in combination with a stimulant like cocaine or methamphetamine. So, given this as background, it's really important to think about opportunities to engage with people who are at risk of overdose. I'm just taking a term that Mark LaRochelle and others have used, Touchpoint, which is an opportunity to identify individuals at high risk of opioid overdose deaths in order to engage them in harm reduction and/or treatment. So LaRochelle and colleagues used a state public health registry in Massachusetts, and they were able to identify that about half of all of the attributable overdose mortality risk was accounted for by contact with systems, including outpatient prescribing, specialty treatment, hospitals, jails, and prisons. I think the key thing to know about touch points is that there are some points of contact that are relatively infrequent, like not that many people overall touch those systems, but the people who are in contact with those systems have very high risk of overdose. So people who survive an overdose and are seen in the hospital, that's a population that's at very high risk of dying of an overdose. People who have been released from jail, likewise. That is another group with very high risk for overdose death. And then there's other points of contact which are much more common but less strongly associated with mortality. Like about half of all US adults have filled a prescription for an opioid analgesic. That on its own is not extremely predictive of overdose death, but it is an indicator that someone might have elevated risk, and then you would want to look at the presence of other risk factors. Similar to the LaRochelle work, my team has also done some work looking at predictors of fatal overdose. We developed a database with the Maryland Department of Health where we looked at records for 3 million people in Maryland, which is about half of the state's population, and followed them across multiple service systems. And here in this study, which was published in JAMA Psychiatry, we basically show something similar to what the Massachusetts team showed, which is that certain touch points are very predictive of overdose death. Probably top of the list is release from a carceral facility. Being on parole and probation, being arrested are somewhat less predictive of overdose death. Being in opioid use disorder treatment, even though treatment itself reduces overdose risk, that's a population that just has a lot of underlying health-related risk factors. People who filled 4 or more opioid prescriptions, and then people who were overdose survivors who were seen in the hospitals, all of those had very high odds ratios associated with overdose death. And in this model, work, we actually ended up developing a predictive risk model for overdose death, and we could find that the combination of these different forms of system involvement was highly predictive of overdose death overall. So we could predict that outcome with fairly high accuracy. So now I'm going to just say a quick word about medications for opioid use disorder. So I think the silver lining of our opioid crisis is that we actually do have highly effective medications to treat opioid use disorder. The National Academy of Science, Engineering, and Medicine sort of said it best in their 2019 report that medications for opioid use disorder save lives. 3 FDA-approved medications, and I won't go into a huge amount of detail about them, but I think the key thing to know is that each of them has a different mechanism of action. Each of them has its role in treatment. Methadone, of course, is a highly effective medication, but it also has safety issues that mean that it often is only used in the context of special methadone clinics, also known as opioid treatment programs. Buprenorphine has been kind of the main expansion point for access. It's available as a prescription medication. Until 2023, there was a requirement of a special DEA license to prescribe. That requirement was rescinded. Naltrexone is an antagonist. It's a medication that can only really be given to patients who are already abstinent from opioids. And the thing is that choice matters. So each medication works for some patients, but the greatest potential for overdose risk reduction comes with methadone and buprenorphine, which cuts risk in half or more compared to treatment without medication. So the question is, given the effectiveness of MOUD, why is it not more widely available for people in crisis? And it's really a combination of a number of factors, and I'll elaborate on these in my talk today. One of the big ones is controlled substance regulation. So as mentioned with buprenorphine and methadone, these medications are subject to a lot of regulations from the DEA. To some extent, these regulations are being loosened, or some flexibility has been provided around these regulations. I'm happy to talk about what flexibility now exists. Financing, so making sure that not only are these medications are covered by insurance programs, but that they're not subject to sort of unusual oversight or prior authorization, that the medications are affordable, and that providers accept all forms of insurance. Then the fragmentation of systems. Drug treatment itself is a system that doesn't exist that comfortably within mainstream medical care. And then the reality is that many patients with opioid use disorder also are involved in other systems of care, some of which are actually hostile to medications for opioid use disorder, which gets into the final factor here, which is stigma against medications, and a pervasive narrative that medications replace one addiction with another, which is not actually how they work, but I think has been a major hindrance to getting more people on effective medication treatment. So with that as a background, I'm going to now talk a little bit about some of the work that my team has done on MOUD access in the context of specialty care. And I think one of the key settings to look at is residential treatment programs. So what is residential treatment? Residential treatment is basically inpatient, 24-hour clinically monitored care. It's intended for patients who have high acuity, sometimes patients with kind of a dual diagnosis. But paradoxically, it's actually one of the least regulated settings of care. And there's actually not much in the way of federal oversight of residential treatment, and state regulation is also kind of very dependent on the individual states, as I'll talk about in a minute. Medications for opioid use disorder are a real challenge to get to patients in residential facilities. I was involved in an audit study using kind of a mystery shopper methodology, where one of our team members posed as a woman who wanted to get treatment for heroin use and was shopping around for residential treatment programs. Only 29% of the programs she called offered her any kind of medications for opioid use disorder for maintenance when she asked for it. And we found that ability to get medication treatment had basically no correlation with whether or not the facility had accreditation from CAR for the Joint Commission, which suggests that really like accreditation is not, which is supposed to be a marker of quality, is not really ensuring access to standard of care treatment. We also found that our caller was offered a lot of non-clinical inducements, and there were a lot of predatory financial practices. So this setting we felt had a lot of room for more oversight from regulation and a greater role for accreditation. And I think it raises the question about what policy interventions can really be put in place to increase access to and use of MOUD in residential facilities. Which brings me to a case study that's been of interest to us. It's not a state that I think a lot of people have thought about in the context of MOUD, but Louisiana is a really interesting case study. So Louisiana actually happens to be the state with the highest proportion of all SUD treatment, substance use treatment, taking place in residential facilities. So for whatever reason, that state has had a higher than the national average reliance on residential treatment. It's also a state with very high overdose death rate, which has been rising rapidly in recent years. And it's been a state that has had quite a lot of policy change. So in 2016, Louisiana joined the Medicaid expansion under the Affordable Care Act. So they were a little late to that. Most states expanded in 2014. They then received what was known as a Medicaid Section 1115 IMD waiver, which allowed the state to start billing Medicaid for residential services, which is something that the Medicaid program historically has not been willing to do. And under the terms of that waiver, they started providing methadone maintenance treatment for the first time in 2020. So Louisiana, unlike most states, was not providing coverage for methadone services prior to that time through Medicaid. The other interesting thing about Louisiana, and this is a fascinating policy case study I'm happy to talk about, is that starting in 2021, the state required all residential treatment facilities to provide access to at least 2 forms of MOUD. They were really, I think, the first state that had that kind of requirement on residential facilities. So I'm going to show you some data related to that now. So I'm going to first start with the outpatient setting. So what we did is we took working with the Louisiana Office of Behavioral Health, we analyzed some data on trends in the use of MOUD, and we looked at it for patients in both outpatient and residential programs. So this is a study that was published in Health Affairs in January. It was led by Olivia Sugarman, who's a postdoc at Johns Hopkins. And basically what we showed in the outpatient setting is that there was profound growth in the use of any MOUD starting in 2018 and going through the end of 2021. So only just a little bit more than 20%, 23% of all Medicaid beneficiaries with an opioid use disorder diagnosis were receiving MOUD in the beginning of 2018, and then that had almost tripled by the end of 2020. We can see that much of that change is due to increased use of methadone, but what you also see pretty clearly is that the state starting coverage of methadone services led to a big bump in the use of that medication among patients in outpatient treatment. Naltrexone was relatively uncommonly used among outpatients in Louisiana. And now I'm going to show you the same trends, but for people who in any month were in residential treatment programs. And what you can see for this is even greater growth in the use of medication. So it goes from under 10% in 2018 to almost the same rate as the outpatient rate. So almost 50% or about 40% in the end of 2021. Almost all of that increase is due to increased use of buprenorphine. Naltrexone also somewhat commonly used, actually the most commonly used medication at the start of the study period. So that stays flat, and very little use of methadone while patients are in residential programs. You can see that a lot of this change is happening before the implementation of that January 2021 state law. But what we've learned in talking with policymakers in Louisiana is that the state was doing a lot of outreach and technical assistance to the residential programs to make sure that they could come into compliance with this law. So I think that there's a kind of an anticipation effect that we're seeing in the data, which is interesting. I'm going to keep moving on, but if anyone has any burning questions, I'm also happy to just take them as I come, because you might forget them. Okay. So we dug even a little deeper, and this is some work that's under review. We wanted to look at the dynamics around the time of admission to a residential treatment program. What we hypothesized is that residential treatment programs would be a source of disconnection from medication. So patients who were on medication prior to going to a residential facility would tend to drop off because residential programs are often kind of hostile to medication. So what we did is we constructed a time series for patients where the index week was the week of their admission to residential treatment. And then we looked back 20 weeks, and then we looked forward 20 weeks to sort of see what changes. And you can see that in any week, the use of any MOUD is quite low. These numbers are lower than in the previous slide because these are weekly rates. You can also see that there's a bump in the incidence of overdose right before an admission to a residential facility, which is, again, not surprising because that's often a crisis moment when patients are starting their treatment experience. They've overdosed and now they're starting residential treatment. And then we also look at these dynamics by types of MOUD that the patients are using. So this is the same data from the previous slide, but also showing use of methadone, buprenorphine, and naltrexone. So let's see what happens after residential admission, and we were shocked by this. So to our surprise, what we find is that there's a big spike in use of medications actually in right in the week after admission to a residential facility. Almost all of that is due to use of buprenorphine and naltrexone. And what we actually see is that there's a dip that takes a while to recover in use of methadone. But then I think the other important thing to notice is that after the spike, use of medication tends to taper off. So there's a problem with sustaining gains that have occurred around the time of admission to a residential program. And then to sort of further illustrate the dynamics around this issue, what we do is we create this kind of plot where each of the bubbles, which is scaled to the number of patients, which represents a unique facility that treated at least 100 patients during the study period. So we show on the x-axis the rate of MOU, the average rate of MOUD for patients at that facility. So take program A, just shown there as one of the biggest bubbles. So about 21% of their patients were using MOUD in the year prior to admission. And then we look at the same group of patients for the year after they were admitted to residential. And we can see that for that facility, it went up to almost 60%, but there's a huge amount of heterogeneity. The interesting thing, though, is that you can see that compared to the 45-degree line, which would represent perfect equality between pre and post-admission rates, virtually every facility in the state is boosting MOUD use among their participants, but often from a very low rate, and that facilities that have lower post-treatment MOUD use are also ones where patients kind of were using it at low rates before. Probably a lot of that has to do with the just geographic heterogeneity in a state like Louisiana, that there's some regions of the state where MOUD use is just very low before and after experiences with residential treatment. So what we do is we kind of disaggregate facilities into these buckets of high, medium, and low MOUD use. And we do the same thing of looking at patients who go to those facilities in the weeks before admission and then after. And what you can see is that there is a boost for all three groups of facilities, but that the gains are higher and are sustained at a much higher rate in the highest group, shown in blue. And then they sort of tend to taper off a little bit less in the orange group, and then they really plummet in the low group, shown in gray. And these are estimated means from interrupted time series models, but the crude kind of unadjusted data look very similar. I feel like I'm going fast, and I really would love to take any questions if there are any, but I can also plow ahead. Related to the same project, we did some qualitative research. So we were asked by the funder, Arnold Ventures, to look into the possibility of using licensure requirements to increase use of MOUD in different kinds of substance use treatment facilities, especially residential. So what we did is we looked at a limited number of states that are sort of in the vanguard in this regard. So there's like Louisiana, New York, and California have some greater legal and regulatory requirements related to access to MOUD in treatment programs. And so we talked to state officials, we talked to treatment providers, and we had some interesting themes come up from this work. One of the interesting themes is that there was perceived to be a trade-off between increasing access on the one hand and ensuring that there's minimal quality standards. So here's a quote: "You're not a social service provider, you are a medical provider, you need to offer appropriate medical care, and that's our expectation when we license you." So that's the perspective that, like, we expect this, and this is a minimal quality standard. But then another state official kind of expressed more ambivalence, saying, as we improve quality, we risk losing what limited access to services we have in some regions. So there is like a worry that making these standards could actually drive certain providers out of business, which would be bad for kind of geographic access to treatment, which is already a challenge. There was also kind of an interesting split on the relative value of doing education versus more punitive enforcement. So this respondent said, well, most of your providers want to keep people safe and have good treatment. Regulatory authorities can get overly punitive and not have a technical assistance focus. And to me, that's really key. If you want to make change, you don't just declare them. You have to listen to your providers and you have to include them all along the way, even if they're coming with you kicking and screaming. And then the alternative perspective, I think that the soft approach is nice, but that the only real way sometimes to make change is if it's the law, because then when there's a consequence associated with it, it's a lot easier. This was a quote from a treatment provider who was not that excited to have to provide MOUD, and their rationale was that they were just respecting the choice of their clients. And they say, what we're doing is not because we've decided that medication is a bad thing. It's because we're listening to our clients. This is what they want and feel, and this is how we're going to treat them. So they felt like the state kind of looking over their shoulder and looking at medication use rates was not really respecting the fact that the patients that went to their program didn't want medication in the kind of the eyes of that provider. And I do see there is a question in the chat. And there's a great question about from Lindsay about how restrictions from MCOs might affect length of stay in residential facilities. And MCOs are a really complicated dimension of this, and I'll try to come back to them at the end of the talk. Okay, so just keeping an eye on time. I'm going to be relatively brief in this area because I really want to make sure I have time to talk about jails and prisons, but I did want to just quickly highlight some of the work that my team has been doing on MOUD access in hospitals and through EMS. So, I'm sorry. Yeah. So I was talking with Dr. Post before my talk about Gail D'Onofrio at Yale. She, of course, is associated with a landmark study that showed that buprenorphine right after an overdose in the emergency department is very helpful for patients seen in hospitals, despite the strong evidence for providing buprenorphine and actually methadone too in the emergency department. There's very low adoption of this clinical pathway in hospitals. And we do know that some states are really trying to incentivize the provision of buprenorphine in the emergency department. We've done some work with Pennsylvania, where there was a statewide hospital quality improvement program, which paid incentives to hospitals, and they had to get these extra payments from Medicaid. The hospitals had to attest that they were providing different pathways of care, one of which was buprenorphine in the emergency department. And they also stood up a learning collaborative led by the Pennsylvania Health System and Hospital Association. So we looked at the impact of this Pennsylvania incentive program using Medicaid claims data in partnership with a team at Pitt University, and looked at the impact of being exposed to a hospital with this clinical pathway in place versus those that were not on post-overdose treatment outcomes. And we actually found a very large effect of this program on use of buprenorphine. So there was a 2.6 percentage point higher rate of buprenorphine use in the 30 days after hospital discharge following HQIP implementation. But that represented about a 50% increase over the baseline. That effect actually got larger in the second year that it was in effect. So I think it was a sort of a phased in thing. no change in use of other medications or non-medication OUD treatment. So really it was an intervention that was effective at increasing buprenorphine use specifically. And then we also did some key informant interviews. I'm not going to read all of these quotes, but I think it was really interesting to understand some of the sort of the non-financial barriers to providing buprenorphine in the emergency department. Stigma is a big deal still in hospitals. And just having a lack of comfort with using the protocol and just a fear of making mistakes, but also a recognition that having sort of state buy-in on this protocol was really important and signaled that there was broad support for doing this. A fairly novel intervention that we've also been involved in studying is EMS-facilitated buprenorphine. This is actually an intervention that's very similar to what's done in the hospital, but this is one in which basically paramedics administer buprenorphine to someone in the field under the supervision of an addiction medicine clinician who's based at a hospital. One of the key reasons to offer this intervention is that many people who are revived by paramedics don't want to go to the hospital with good reason, and I can talk about why, but one of them is they have been mistreated very frequently in the hospital. So we studied the phased roll-in of the bupe-equipped ambulances by Cooper University, which was one of the first places to do this. So they started this in 2019 and rolled them out in a staggered manner, which provided a nice natural experiment. And so we were able to look at the medical records of 117 patients who were treated with the bupe-equipped ambulance matched to controls who didn't get treated by the bupe-equipped ambulance. This is sort of the big finding. So the one place where we saw a very large and significant differences was the percentage of patients who were in treatment 30 days after being treated by the bupe-equipped ambulance. So we didn't see big differences in transport to the ED. If anything, the refusal rate was slightly higher among those patients treated by the bupe-equipped ambulance shown in blue, which also makes sense because they may have been feeling like, you know, I just got the medicine, I don't need to go to the hospital, even though they were encouraged to go to the hospital. There was a difference, but not a significant difference in overdose after being treated, but it really was a big difference in terms of continuing on to treatment with the Bridge Clinic in the 30 days after being treated by the bupe-equipped ambulance. So 35% versus 9%. In our adjusted odds ratio, I think it's an odds ratio of something like 5. Okay, zipping right along, I'm now going to talk about an issue that's been occupying a lot of my attention in the last few years, which is MOUD access in jails and prisons. So to take a step back and kind of going back to what I was saying at the top of my, my talk today, overdose risk is very high in the weeks following release from jail or prison. People become incarcerated, they use at very high rates before they're incarcerated, and then they undergo forced withdrawal in jail or prison. One of the things that that does is reduce their tolerance so that someone might go out and use the same amount of opioids as they did before they were incarcerated, and it's just much more fatal to them. We know that most jails and prisons don't offer MOUD despite the incredible need. And also, there's a lot of stigma among community corrections providers of parole and probation, and they are an important source of referral to treatment after release from a carceral setting. So we've done a lot of work on cataloging the barriers and facilitators to MOUD implementation across a variety of jails and prisons, and it's been very informative. So this is just some data from a Bureau of Justice Assistance report that came out recently, just kind of making the point that I just made, which is that even basic practices like screening for opioid use disorder at intake among US jails in 2019, it was only done about 60% of the time. Providing medications for withdrawal, which aren't always necessarily medications for opioid use disorder, only about 50% do that, and then continuing or initiating medications for opioid use disorder, only about 20% of all jails in the country do that, and often do it at very low rates, and also very low provision of the overdose medication naloxone upon release. You can also see that there's a lot of geographic heterogeneity. The most common color on this map is yellow, which is states where only about 10 to 20%. I'll note that Illinois only does slightly better than the national average. And I just recently published a perspective in the New England Journal talking about some exciting developments in Medicaid policy that now allow states to get reimbursement for some services provided in carceral facilities. It's a new Medicaid option, and it requires that among the services that are provided to Medicaid members before release are medications for opioid use disorder. So in some qualitative work that we published in 2021, we just sort of walk through the challenges at every phase of interaction with the carceral system, starting with entry and being screened for OUD treatment, for opioid use disorder and for treatment, getting a kind of a timely diagnosis and getting started on medication. Very complicated logistics around dispensing medications in jails and prisons, and lots of concern about medication diversion. So it takes up a lot of staff time, both on the custody and medical side. And then a variety of different program requirements with lots of facilities sort of creating requirements that people participate in counseling, that they taper off medications and so forth. And then a kind of a critical bridge during reentry for follow-up care and making sure people are connected to community programs after release. And yet, despite all these hurdles, we also know this is a time period of incredible growth. So this is just some data that we looked at on buprenorphine in jails and prisons. And we can see that there is just an explosive amount of growth starting in 2019. And this growth, I think, is still continuing. I'd like to extend this data just to see what the last couple of years have brought. And that brings me to some of the work that we've been doing in Maryland. So Maryland was a national leader in passing a law in 2019 that requires all jails to screen for opioid use disorder, offer all 3 medications, and provide comprehensive reentry care. I'm the PI of an R01 from NIDA that is doing a mixed methods evaluation of this law. We're going to be using similar kind of linked statewide data to those that I described at the beginning of my presentation, and then also looking at some of the heterogeneity and post-release outcomes across racial and ethnic groups and geographic areas. And then right now we are in the thick of qualitative interviews with wardens, medical staff, reentry coordinators, and also with recently released people. Sorry, I'm going backwards. In terms of our interviews with medical and security leaders, we're hearing a lot about their concerns with funding, that this was an unfunded mandate that the state handed down on them, which they're not thrilled about. A huge amount of concern about diversion and how medication in their facilities is creating security concerns, how it's creating kind of difficult dynamics between incarcerated people. It's not the kind of thing that I was expecting, but it's been very interesting to hear about. Feeling like there's a lack of coordination and planning statewide, but also a wait and see attitude. So some wardens that we talked to kind of had the perspective that they were not 100% for this or against it, but they were waiting to see how it was going to work out. And then I just want to share some quotes from some of our interviews with recently released respondents. These are very preliminary quotes. So some people we talked to were actually very much saying that the program they got in jail was helping. This person said that the difference, as opposed to the past, is that I would have had to withdraw off everything before while I was in there. And then last time I was there and they passed the law, I didn't. Another person said, you're in jail anyway, so why not? A lot of people can kid themselves and say that they're going to stay clean, and maybe some do, but I know a lot of people that got out and the very next day they got out of being locked up, they were dead. Contrary to the perspective that medication programs promote diversion. This respondent was talking about how it's actually helped cut down on the illicit use of drugs in jail. So this person said it creates a market when they don't offer it, and so people have it in there and they charge crazy amounts of money, and there's all kinds of fights, and it's just insane. Oh, I'm so sorry. And it happens way more than people realize. And then to go somewhere where they have it, it was completely a whole different atmosphere. And then this person talking about how it helped with their reentry. My mindset was different when I came home. Usually I can't wait to get home so I can get back to doing what I was doing before. But this time around, I wasn't even doing that. I wasn't even thinking like that. I wanted to maintain the things I was doing and keep myself drug-free for as long as I possibly could, give myself a chance. And I did it, and it worked. Finally, I want to talk about some of the advocacy work that we've been doing in this space. One of the things that we really tried to push for, and we were so thrilled to see that it came out in a SAMHSA regulation this month, is greater clarity about the fact that methadone can actually be dispensed in jails and prisons outside of the structure of opioid treatment programs for facilities that possess a different kind of license for hospitals or clinics. And we outlined that in a white paper, and then we were just so excited that SAMHSA also affirmed that that was the case in the regulation that they released in February. And so now we're doing a lot of work to try to build awareness of this new policy opportunity to provide methadone to incarcerated people. So I am going to wrap things up here so we can have a little bit of Q&A. So I want to talk about some directions for research and policy. So a lot of what I've been talking about has been the move toward what is I'd call low threshold treatment. So treatment provided on demand when people need it in the setting wherever they happen to be. And the question is, where do we go from here? This is a photograph. I took like a very mini sabbatical last year and went, among other places, to Portugal to learn about that country's experience with drug decriminalization. Actually, one of the things I learned there was how important the creation of community treatment infrastructure was. This actually is a photo I took of a methadone van that sets up outside of a water treatment facility. A lot of the gentlemen showed here are just stopping in to get their methadone dose. They can, hand in their used syringes. They can get some safer use supplies. They can get Narcan. It's like the most low threshold program you can imagine, because it's really like stop and go, come and get what you need, and very different to the dominant model in the US for how patients get methadone. But we're also very interested in how this kind of model might work in the US. And in 2021, the DEA actually created a new policy pathway for mobile treatment using vehicles, not quite like this one, but to treat patients with methadone. So I also have an R21 from NIDA to study the implementation of that program in New York State. But this to me is like kind of the inspiration. How can we get a little closer to this model? I think there's some big questions that need to be resolved around models of care delivery, like what works and why. So mobile medication units are a good example of that. These are good options for some patients, but not for all patients. So who can benefit from these sort of alternative modalities of delivering care? The thing that I've become really obsessed with is questions of scale. So every intervention that I talked about, treatment in residential programs, treatment in emergency departments, treatments in jails and prisons, they're being offered, but not to enough patients to make a public health difference. And why is it so different? Why is it so difficult to scale these interventions? Why is it so hard to actually get large numbers of patients onto the protocol? I think a lot of it has to do with the restrictions and the resource limitations that programs encounter kind of just in the logistics of getting these done. So I did not set out to become an implementation science researcher, but I find myself very interested in implementation questions. And then, of course, financing is always in the background. Could better payment models solve some of these systems integration problems? How much could we actually explore the limits of alternative payment models to try to encourage more care integration across systems, like between jails and hospitals? That would be a good example. And then not all of this is about promoting more high-value care. It might also be questions of disadopting low-value or questionable care. So these are questions I'm posing. I don't have answers to all of them, but I just will end there by stimulating a little bit of discussion on some of these topics. And I love this quote: "The future's already here. It's just not evenly distributed." So really, a lot of the models that we need already exist. We just have to go out and find them and figure out how to replicate them. I want to definitely acknowledge funders and a whole bunch of collaborators, only some of whom are listed here, and to just emphasize that all of the views presented today are my own and not necessarily those of my funders. And with that, I am more than happy to take questions. Thanks.
I have a bit, this is Lori. I have a question to ask you. So what do you think about naltrexone? Like the evidence on naltrexone, because I hear very diverse responses to that.
At this moment, I always give the disclaimer that I'm not a clinician. So I really try to go by how I understand the clinical evidence. And what I understand to be true is that if a patient is willing to start naltrexone, which is a big if, because many patients are not indicated for naltrexone because they're not fully abstinent, and it's difficult to achieve that abstinence. They get a protective effect from naltrexone during the period of time that they, that they have the medication on board, which is 30 days. A lot of patients don't want to get that second shot. They don't tolerate naltrexone that well. But I would say that we still need to have it as one of the 3 medications for opioid use disorder, because there are some patients who want it. They don't want to be on an agonist medication. They may have good reasons to not want to be on an agonist medication. And so having the choice to take a shot of naltrexone can be, valid and important. But I would say that from a public health perspective, we have much stronger evidence for buprenorphine and methadone than for naltrexone.
Thanks. Can you see the questions there?
I can, and I'm happy to just sort of read them off and answering them. I kind of dodged the question about MCOs beforehand. I think MCOs, which are Medicaid Managed Care Organizations, are a really interesting dimension of policy experimentation, I guess you could say, because so much kind of rides on whether MCOs do a good job of promoting care coordination. I've seen state Medicaid programs provide special incentives to MCOs to meet quality targets. I think we should experiment a lot more with that for MCOs and try alternative payment models to get them to do things like increase the use of MOUD among their members, or to reduce hospitalizations among people who are at risk of overdose, especially preventable hospitalizations. So I think that's Lindsay, if you have any follow-up questions, those are my thoughts. Then Alex Lundberg said, "I've noticed a common theme in the literature is to say any MOUD can be an effective treatment, which feels insincere. My sense is that methadone is more effective than buprenorphine, especially because studies tend to ignore the selection of higher risk patients into methadone. Is my sense of the literature off? I'm confused because when I talk to MDs, they all seem to prefer buprenorphine." Really good question. Kind of same disclaimer that I gave before. There's a lot of complicated clinical issues. One of the things that is getting discussed a lot now is that with fentanyl so ubiquitous in the drug supply, many patients are responding more favorably to methadone. I think that head-to-head evidence between methadone and buprenorphine would suggest that they have very similar profiles in terms of overdose risk reduction. Some of the concerns you have about patient selection are mitigated because some of that evidence actually comes from randomized controlled trials. Buprenorphine is probably preferred by a lot of MDs just because of the logistics of getting patients started on it, that it can be done in an office-based setting, whereas methadone requires most patients to go to methadone clinics. So there's kind of a structural stigma against methadone that might cause some of that kind of ambivalence or reluctance to use methadone. Buprenorphine's also got a more favorable safety profile. It's much harder to overdose on buprenorphine than methadone, and that's another reason why some clinicians may prefer it. So that's a good question. And then another person said, have I seen a connection between this and domestic abuse, and that is not an issue I've looked into. So I will just say I don't know. Yeah, and then Stephen asked, what do you think motivated Louisiana to pioneer in this topic, given its more conservative policies? Maryland surprises me much less. Yeah, Louisiana is an interesting one because actually this particular law requiring residential facilities to provide medications kind of snuck into a legislative session. I'm not even sure that the sponsoring legislator totally understood what they were sponsoring. A technical assistance provider that was working with the state actually helped write that legislation. So it's sort of an interesting example of a little bit of unpredictability, a little bit of serendipity, causing a generally more conservative state to adopt a more progressive state law. The state agency that ended up having to implement that law was a little bit blindsided by it. So they were surprised, but they did what they could to make sure that there was a strong compliance response among their providers. So Louisiana still has a long way to go, but they've made a huge amount of progress, which is sort of the message of the paper that we published in January. Thanks for that question.
So let me thank you so much for joining us. And I want to thank everybody for attending today. And then this will also be made available and we'll send out the link afterwards. So thank you, Dr. Saloner.
Thank you. Really appreciate it. Good to be with you all.
Right. Bye-bye.